Hello, everyone around the world. Today, we have a great webinar for you. Thank you for joining us. We have an hour webinar planned. It is about private sector engagement in TB care and prevention. And we're focusing today specifically on the realities on the ground. I'm very excited that we have some great speakers with us today. We have Shibu Vijayan from New Delhi. He's joining us from India. He's the Global TB Technical Director at PATH, and he's heavily involved in the JEET project in India. He has over 25 years of experience in India in a broad spectrum of public health related issues. And his focus has been very much also on the private sector engagement. So we're very much looking forward to his experiences and his perspectives on the work with the JEET today, and especially with the influences of the COVID pandemic in India, how the situation is on the ground, how their project has been needed to adapt, and what their realities are. Also with us is Bolanle sorry, I'm gonna say this wrong and I've practiced it so many times. Bolanle Olusola-Faleye, and you can say it probably better. Thank you so much for joining us from Nigeria. She's working as the TB Technical Director for the Shops Plus project in Nigeria. She has many years of experience in program management related to HIV and TB, and also drug-resistant TB within Nigeria. And she comes recently from KNCB and is now leading the projects in Nigeria. And we very much look forward to hearing on the situation in Nigeria and on the project that Bola is leading in Nigeria. And we also have in our panel Dr. Madhupai and William Wells. He's the Senior TB Advisor at USAID, and he will be moderating the discussion. So the plan for today is we're gonna be listening to a presentation first from Shibu for about 20 minutes. Then we will go straight into a presentation from Bola, also for about 20 minutes, and then we have about 20 minutes left for a discussion. So what I would like to ask everyone, if you have any questions, feel free to put them in the Q&A directly. We will pick them up during the presentations. If you have any clarifications or specific ideas, also please post them in there. We will look at all your questions and we will moderate them afterwards. So the session is recorded. The full hour will be available afterwards for anyone who wants to see it. And with this, I would like to give Shibu the chance to start loading his presentation, and you can take over as soon as you have the presentation online, Shibu.
Sure. So thank you, Petra, for the nice introduction. So I would want your permission to share my screen.
Yes, please.
That is.
Can you? Is it working, Shibu?
It's actually saying that I need the host permission to. It says that it needs host permission to actually.
To share the screen?
Yeah, host is disabled participant screen sharing.
Oh my, sorry, that is very weird. What I will do in that case, I will upload the presentation. I'll share the screen from my end. Okay. And I've never had this before. I'm really sorry about this. No. Let me figure it out. In the meantime, I will upload the presentation, your presentation from my end. And Shibu, if you can please just prompt me. Can you see it?
Yes.
Can you prompt me when you want me to move on to a different slide?
I will do that.
Okay.
So thanks Petra, and also apologies for that technical hiccup. So in the next 20 minutes, I'll be talking about how the JEET project actually got consumed by the COVID epidemic in India. And I'm solely going to delegate this time to the tuberculosis, how it affected tuberculosis, not actually venturing into the COVID activities and stuff like that, what government of India is taking. I think that is not in the scope of this discussion. So the presentation is actually layered in introducing what is actually JEET, and then how the JEET model is being deployed in India, and then how disruptions happen, and then what are the mitigation measures we did. To be very honest, we are just still figuring out. We don't have full solution yet, and then because the country is still on lockdown, on a sequential lockdown, and the operations are 80% of the operations are private operations are still actually not fully functional. So still, I mean, this is a work in progress. Anything any mitigation or any further actions actually depends upon how we figure out. So next slide, please. Peter, next slide, please.
Can you see the next slide? No?
No.
Petra, hit that enable editing button and then it should be able to move.
I'm sorry. Let me go out. I don't know how.
Okay.
Yes.
So there was a slide before that. Okay, cool. So the second slide. Okay, cool. Thank you. Stay there. So JEET is being implemented by 3 partner organizations with support from the Global Fund. The partner organizations are Clinton Health Access Initiative, local entity, which is William J. Clinton Foundation, and PATH local affiliate Center for Health Research and Innovation, and then FIND. So we cover almost 23 states and then roughly around 400 cities, and we have intense operations in 50, broadly around 50 cities. The other cities are actually more like a technical support to the national TB program to engage the private sector. But in 50 cities is actually hardcore engagement with the extra human resource for aggressive engagement of the private sector. So we intend to cover roughly, around 15,000 plus doctors in this initiative. Move on to the next slide. Okay, good. So there are essentially 2 models. One is the private provider support agency full model, and the other one is the private support agency light model. The full model is actually, as I mentioned, there's a provider engagement component and a patient service component, and there is an interface between the national TB program, and also this project is actually acting as an interface between the private sector and the NTP. And from the provider engagement, we have dedicated human resource for engaging and relationship management. It's actually going and messaging the right practices in tuberculosis control. What do they do for diagnosis? What do they do for treatment prescriptions? And where are these quality services available? And also providing sample collection, transportation, and human resource support for patient registration and notification as in-clinic support to the doctors, and provisioning government drugs and other logistics if they are willing to actually kind of utilize that. On the patient side, there are dedicated human resource for counseling, adherence support, and as well as public health actions, which includes patient subsequent profiling for HIV testing, diabetes management, and also the contact tracing. And essentially how the linkages with the public sector is actually the model is being designed to leverage all the supplies from the government. That includes the drugs and diagnostics from the government, if the doctor is willing to actually leverage that. And our motive is to actually push towards that, to get that behavior inculcated to utilize the government services, and the notification for both the treatment initiation as well as the treatment outcome notification is being done through the government system called NICSHARE. So the entire activity is being supported by the supporting agency. Whereas in light model, it is largely, as I mentioned earlier, it's technical support. It's a limited provider engagement. It's mostly for capacity building to the NTP staff, direct involvement with the RNTCP or NTP staff, and then support NTP for reporting notifications. So essentially, the focus is largely on the PPSA model. Earlier, it was known as PPIA. Now, the Government of India has actually changed the nomenclature into the PPSA. So move to the next slide. Slide number 4. Okay, so this actually depicts the service delivery model. So there is a field officer, which is actually who have these are actually staff which is having skill set to engage the private sector doctors. They were in the marketing, medical marketing space earlier, so we recruited them. So they kind of message the right messages and also push to change their behavior to utilize the government services. And there are sample hub agent, which is actually to support the government, the private sector heavy load clinics. To manage the patient reporting and recording in the NICSHA, and also a little bit of counseling for the patient to come back every month and stick on to this doctor, this provider, so that we are not actually taking the patient away from the doctor. We are retaining their clientele and then supporting them for the public health responsibilities like notification in time and also to follow up in time. And there are support system for sample collection, transportation going to the government, essentially going to largely to the government CBNAT sites or gene expert sites, or in a minimal amount is actually going to the private sector as well, private sector lab as well. The Global Fund recently allowed us to procure the service from the private sector also if there is a demand, if that is needed. And the drugs are predominantly, as of now, predominantly is coming as prescribed, and the patients are being taken from the private. Roughly around 20% of the needs of the private patients so far, notified private patients so far has been met only by the government supplied FDCs. So this model actually shows there are field officers for managing the patient-doctor relationship. There are treatment coordinator for actually supporting the patient for adherence. There are sample collection agents for the sample transport. There are also hub agents, which is actually a clinic assistant to the doctor for recording, reporting, and minimal patient engagement for public health responsibilities. Move on to the next slides. So now that actually what has happened over last 2 months, actually because of the sequential lockdown, and it disappeared. Petra, the slides are not.
Yes, keep going, Shibu.
So the disruptions, because of the disruptions. I mean, I'm not able to see the slide, but I am hopeful that.
Yes, they will come back.
Okay, fair enough.
Please
okay, so the transport is actually closed, affecting both patients and the service providers. Nearly 80% of the private provided facilities are closed. Now, as we speak, from last week onwards, there is actually minimally they started opening up, especially in the state of Maharashtra and Madhya Pradesh and Delhi and all these places like Gujarat, all these places actually started opening up. Government also issued orders to actually it needs to open, but UP is still closed. So there are also, we have noticed a safer clinical practice from the doctors. They are not from private doctors. Their fever and cough patients have been largely directed to the public sector. So there is a fear among the private as well. Okay, no to entertain in potential in COVID patients. The pharmacies has been closed in the initial days in many places except for the cities. The health workforce has been largely diverted for the COVID response. Health staff, there was concern about processing sputum samples, especially in the public sector. They don't want to venture into that because there was PPE shortages in the initial days, which has all been now addressed to a large extent. Diagnosis actually got badly impacted in the private sector, both from the demand side as well as there are transport challenges. So demand side means the patient were not able to go to the facilities, or no, they were reluctant to go both, and there were no clinics, services available. So as you see them, so if you can go to the next slide, I'm not sure. Has it been settled now?
Should be good. You see it?
Yeah, I think I can see it. So this is slide number 6, correct?
Yes.
So before COVID, if you look at the 2018 and 2019 notifications, this is all NICSHA data. This is not project data. This is all NICSHA data from the government, which we have downloaded couple of, 1 week before. So if you compare with 2017, as if you take that as a baseline, you could see that almost 152% increase was notification was noticed in Q2. And there is a slight dip in Q4. I think pretty much every Q4 shows a dip, but except for 2018, there was actually again an upward trend. But generally, which we see there is a dip in. And also in the last quarter, in few states, there was some sort of civil unrest, which actually also interrupted services and also some data entry. So essentially, the JEET and all this bump, roughly around 40% is being reported from the places where the Indians PPSAs are present. So the attribution for this JEET for this bump is roughly 40%, I would say. So, so from this, the scenario starts. If you move to the next slide. So this is the dip what we are now seeing. So you could see from January, February, March, and April, notification kind of plummeted from February onwards, because that was the early days of February, mid of February, early days of COVID response. COVID actually coming in, and mid of March, we had this lockdown, which you see, sharp dip in that. So if you do that if you take January 2019 as a baseline, a benchmark, and look at that, how it is actually affected, there was initially, in the initial January month, we also saw a bump of plus 3% compared to last year. But apparently in the subsequent months, it is hardly hit. Almost minus 76% dip in case notification. Multiple factors are there, as I mentioned. There is staff not able to move. There are cases little bit diagnosed, also not getting entered or not getting notified. So the multiple scenarios are there. But again, apparently this actually gives a picture of how bad this COVID situation has actually hit the TB services. Move on to the next slide. So this is the problem. So you have seen the problem statement and NTP. I'm now going to talk about NTP response and also some of the responses what we took actually. So naturally, as NTP, as every NTP globally has done, actually sent advisory to the respective service delivery. The provinces and the service delivery units at the district level. Largely focusing on uninterrupted service delivery to the patients. There is a toll-free helpline which is already functional, now being extended to all the patients. They can actually call and then understand about understand about where are the service delivery points, and then accordingly manage. Seek service. And also infection control measures, protecting the TB patients, and also service providers, as been mentioned. The 1 month drug dispersed to the patients who are on treatment. There are also advisory to issue TB patients if they require travel already on patient, and there are ICT tools and for counseling and adherence, because these are actually mentioned from the NTP manager's letter. There was multiple advisory, 3-4 advisories gone to the respective states for adhering on. Next slide. So the Global Fund also actually respond to the COVID was allocated extra money. So that's something good. So they have sent us, they've clearly given us, to utilize 10% of the total grant amount for the COVID activities. And there was a provision of actually around roughly INR 700 rupees to procure gloves and masks and hand sanitizers for the patient. On the 10% grant, we had actually multiple proposals back and forth with the Global Fund for procuring PPEs for the private sector, but that's still a discussion in progress. Nothing has been kind of finalized, but that is still on. Move on to the next slide. So this is actually how we approach. So this is a framework which internally PATH team actually developed, which pretty much actually captures about how we can protect the existing system, how we can actually kind of mitigate by rapidly adapting the service delivery to ensure the continuity of the system, and also and on the same time support COVID response, because that's something an immediate response required, and we need also health human resource to support that. So pretty much actually I'm going to discuss something in the next slides is the philosophy of this has been kind of captured in that. So one of the key components of the private sector engagement is, as I mentioned, it is largely the relationship managed with the provider and the patient. So these are two important functionaries in our work. So the providers actually, if you're not maintaining that relationship, it will be good. It will be very hard to actually kind of re-establish that and get the services from them. So they probably might switch back to their early behavior of doing whatever they would want to do. So what we have done, though there are restrictions, we actually continue, because over the last 2 years, we kind of actually the champion providers and our staff has already been kind of entered into good relationships. So they increase the frequency of calling for feedback calls, update on the patient status, because our treatment coordinators who are in charge of the patient adherence and support details were actually kind of capturing the patient status, and then we are giving that to the doctors over the phone and saying that there are certain patients that have been sourced and given drugs from the public sector. It's more of actually keeping them engaged with the project activities as well as the TB control activities. There are good examples, like in Gujarat, the government has actually extended PPE kits for the private sector. That as a scheme for actually kind of keeping them engaged and also encouraging them to open the private services as soon as possible. This is something which we are in discussion with the TB National TB program also to consider that. Probably we are hopeful that Global Fund or other partners will support. We are actually facilitating a costing of PPE for all the TB staff, including private. So let's see that how it is going to pan out. So there are occasions about joint calls with the patient and providers as needed, because some patients would want to actually talk to the doctors. We kind of facilitated that. That's again small thing, I mean, not at a large scale. Monthly email summary of the patient status to the champion providers. That's something which we did that to engage them and keep them actually very active. Then there are some IEC materials developed on COVID and TB, and then Zoom training for the COVID in especially in the Mumbai, which happened. On patient side, we were judiciously doing that adherence call from the treatment coordinators. We are actually contacting them. Facilitated certain doctor consultation as and when required, home delivery of the drugs. So because the patients who are not able to travel, we leverage the drugs from the public sector and then facilitate the home delivery. In certain cases, we also end up in actually supporting the NTP staff to deliver where our staff was not able to travel. And source also government FDC in pharmacies where our pharmacies are not accessible. And some of the emphasis on infection control and encourage patient to report any symptom or exposure to COVID. So both the parties in the scheme were kind of kept engaged by and large without much interruption, but not optimal, but to some extent it was not. So on the preparedness on the pharmacy, the other challenge was the pharmacies were not open in the initial days, and when it got open, we expected, like we also did a dipstick. We did 2 surveys actually. One was done by our team, checking with the pharmacies and also the stockists to understand whether they have adequate stocks for the private patients and whether there were actually occasions of any supply chain interruption. By and large, it has been good when we did, but the bias is that was done in Mumbai. Mumbai, the pharmacies were open. And on the other side, BMGF supported IQA to do a larger survey in 2 states, in Bihar and in Maharashtra. So which also shows that there is no major interruption, but the story is not complete here, because this only says because there is a huge demand issue now, because the new patients are not coming. Existing patients would have actually enough resource, enough actually stock. And if they don't have stock, there was support system already established. So we are not expecting an immediate crunch. But again, what is actually kind of satisfying is there is no immediate problem. Move on to the next slide. But on the largest side when we discuss this with the manufacturers, we could contact both Lupin as well as Macleoids. So the manufacturing process has been affected. This is going to have global implications. They are not very sure even whatever they committed to the government of India, they can deliver. So they are kind of deprioritize the private sector at least at this moment. So that's what their statement says. The stock movement, the process has been affected because of the staff were not able to actually move. They got special permission from the respective governments where their manufacturing plants are situated to enable the staff movement. But still there are challenges. Stock movement has been challenged. Trucks has been stopped in borders. cost of production increased because they have to pay for the staff to stay in a safer place and hotel charges and all these things. There was actually a communication from the health secretary to ban on exporting TB drugs, but it's not imposed yet. The communication went to the pharmacy department. They are still not. There is no advisory gone to the manufacturers to stop it. They also flagged a potential supply challenge in the coming quarter due to when the lockdown relaxes and the demand increases. So this is just for general information, probably for other parts of the world also. Those are dependent on, because the larger part of the drug supply is coming from India. Move on to the next slide. We also made some sort of operational adjustments to, adapt to the situation. We shifted patients to the government FTC, as I mentioned earlier, provided drugs at the patient home. Patients were informed to the nearest pharmacy. So we have a network of roughly around 3,500 pharmacies across, because we have some sort of engagement with them, collecting the register, H1 register, which is actually a list of patients who procure TB drugs from them. And so that relationship, we kind of leverage that for the patient, give that information to the patient. If this pharmacy is closed, you can also go and actually get the drugs from other pharmacies. So that information has been done. So there has been some demand from the providers also. So this, we are not figured out yet how to actually make that allowed to screen all coughing patients for COVID. So the government has never agreed that also kind of create unnecessary panic among the patients. There is a PP requirement from the private, which Gujarat has been addressed to a large extent, but other places is still, and also security from the public here. So there has been incidences about public actually acting very weirdly and also manhandling doctors. So there was nothing related to COVID, but there are some incidents report they would want actually some security also. Move on to the next slide. So we also did a lab preparedness assessment. So as you all know that the TB diagnostic manufacturers also ventured into the quickly actually kind of there was a immediate response from them to actually kind of support COVID also. So they came up with the TrueNat Beta Cov and GeneXpert Express. And we have been constantly actually working with these colleagues, and then we did a quick lab assessment to understand which all private labs can actually run these two tests and then kind of jointly get benefited. So this has been submitted to the government for their actually, if they're planning to actually expand it to private, they can use it. But this is not got much traction as of now, but this is some activity which we done to help them. Move on. So some of the mitigation is that in Maharashtra, we have been collaborating with the Indian Medical Association for a larger, and giving them confidence actually when you are there to open the services, and also as a bridging generally for the government services, and getting and supporting them for COVID response also. Especially in the Mumbai, we also help them in getting the data for the bed availability for the COVID patients, and also ICU availability and ventilator availability. So, and we, that's an association with the Indian Medical Association. Clinton Health Access Initiative is also understanding a dipstick for acceptance of virtual consultation. So now the government of India also came up with a telemedicine platform. So this is just to understand how TB patients are comfortable in getting into this platform, and then what are the adjustments we need to make, and how as JEET we can help them. PP costing, I mentioned, in collaboration with NTP, we are actually helping. We are actually kind of figuring out what is the total cost for PP, and then probably Global Fund, we will approach Global Fund to support it. Online pharmacy for government drugs to private patients. This has been actually again Clinton Health Access Initiative. Chai has been working with other partners to get it done, but it got delayed because of COVID. But there are opportunities at this moment to actually venture and do this thing. There are certain things need to be clarified or set, because any online pharmacy need a prescription, valid prescription from the doctor, so that need to be uploaded. So the new patients getting benefited will be a challenge immediately, but again, this is a work in progress. I think soon we will have something. Move on. I also see an opportunity, because government of India, there has been a sea change in approach to the private sector over the last 3 years, and then recently in the last year there is a lot of changes happened, especially you can see the guidance document on the partnership, which came with a lot, whole lot of behavior change within the government, saying we are ready to pay for the services. Looking at them, it actually talks about an outcome-based actually financing. So this also opens up a lot of opportunities for the provinces and the TB managers to source services from the private sector. So I think there is no policy issue. There is no guidance issue preventing in doing that. But again, there are, I mean, at this moment, this is actually a COVID focus. But when we actually immediately switch the focus, there is a whole lot of opportunity there. Electronic vouchers for sourcing, service from the private sector, payment paid by the government is a possibility. It is also there in the guidance document. Market shaping model, because we have now multiplex diagnostics approved by Global Fund Empowered Review Committee, so which also enables to have multiple diseases to be tested. So can we have market solutions like what we have designed in IPAC? So there is a whole lot of opportunity there. Accelerated private sector engagement, as I mentioned, for full services like LTB and MDR-TB services, taking the guidance from the guidance document. There are 20,000 plus facilities registered under Universal Health Insurance, which is actually the PMJY, these are facilities could be tapped for TB services as an immediate response to mitigate the overload or demand from the TB patients in the coming days. So I'm stopping there. Many of the things are actually work in progress. The mitigations are still to come in the coming days. We hope that things will settle and we'll be in a better shape and we will have spikes in our notification numbers. Thank you so much for the patient listening, and apologies for the hiccups in technology. Thank you.
Thank you so much, Shibu. That was an excellent presentation, lots of information, and I can see that there are questions coming in. I would like to ask Bole, can you try and see if you can share the screen?
Sure, Petra.
It doesn't work?
It's still saying host disabled participant screen sharing.
Okay. I will try and do it from my end. My sincere apologies to everyone for this mishap. That must have been on my end in setting people up. I will share the screen, and please let me know if you can see where I am going, because it's hard for me to check to make sure that you can see it. I have your presentation. Can people see the presentation?
Yes, I can see it. You can just move it down a bit. Yeah. No, I mean, sorry, up.
Up.
To the
it's the highest up. I'm sorry, it's because it is. I have to show it like this. There is no other way I can enlarge it right now in this model.
All right. Thank you, Petra. Okay, so I'll just get on with it. Hi, everyone. My name is Olusola-Faleye, and I'll be presenting on the topic, engaging the private sector in COVID-19 and TB response, realities on the ground. I'm presenting on behalf of the SHOPS Plus TB program in Nigeria. Next slide, please, Petra. So here's our program overview. SHOPS Plus is sustaining health outcomes through the private sector plus. We are USAID's flagship initiative in private sector health. We implement in about 9 countries in the world on a variety of health issues, ranging from TB to HIV to maternal and child health. But the program objective for the SHOPS Plus TB program in Nigeria is to increase TB case detection and treatment through the private sector in Nigeria. Currently, we are working in 15 states and the Federal Capital Territory. Next slide. Here's just an overview of our achievement in 2019. Before SHOPS Plus started implementing, the private sector was responsible for only about 12% of the total TB case notification in Lagos State, one of the states where we work. That state has the highest TB burden in Nigeria. And but currently, we are responsible for about 21% of the total TB case notification. You just hold on a bit for Petra to get to slide 3. Yes. So we have moved the private sector from notifying only about 12% of total case finding in Lagos to about 21% in 2019. And for Kano, we moved from notifying only 3% from private sector in 2017 to notifying about 22% of total cases in that state. Next slide. The next slide shows our hub and spoke model, our approach to finding these cases. So we engage a variety of private providers, a multi-cadre network of providers, with the hospitals acting as a hub, and the laboratories, the community pharmacies, and the patent medicine vendors, those are the drug shops acting as the spokes. So the labs, the patent medicine vendors, and the community pharmacies refer patients and drive patients into the clinical facilities for treatment. And the next slide shows the patient pathway. And we've learned that we have to follow the patient as he moves through the pathway. Our objective is to ensure that wherever the patient accesses care in the private sector, from the facility or the lab or the drug shops or the pharmacies, they're able to be correctly managed for TB. And our objective is to get the patient moving through that pathway, so eventually they get diagnosed and treated if they have TB, and to get the samples moving for diagnosis as well, and to get the data, moving through the entire pathway to the point of notification. Next slide, please. And this slide explains the COVID-19 situation in Nigeria. We started a bit later than many countries. Our first case got into the country and then was diagnosed on February 27th. It's also the first case in sub-Saharan Africa. He's an Italian who just resumed, normally lives in Nigeria, but went on vacation and resumed to Nigeria on, before he was diagnosed. And over the next 3 months, Nigeria has reported over 6,000 COVID-19 cases and about 191 deaths. Next slide. I'm showing the Nigerian CDC dashboard to indicate where the burden of COVID-19 is in Nigeria right now. So you see in the areas where we have the big bubbles, we have one down south in the southwest, that is Lagos, and then we have one up north in Kano. And these are the two states that also have the highest TB burden in Nigeria. And of course, the bulk of the Shops Plus TB programming also happens in these two states that have the highest TB burden and also the highest COVID-19 burden as well. Next slide. So the government took a lot of steps in mitigating COVID-19, and the impact on the TB program is as a result of both COVID-19 itself and the response taken to mitigate its effects. So on March 30th, the federal government of Nigeria announced lockdown in 3 states, including Lagos and Abuja, where we currently implement Shops Plus TB program. Pharmacies and chemists and of course hospitals were allowed to open. They were counted among the essential services that should still be operating. A late starter in Nigeria, that's Kano State, that had no case for almost a month after the other states started reporting cases about a month ago, and so far has over 800 cases. Now, the lockdown in Lagos was eased over 2 weeks ago, and I'm going to go through the impacts of that lockdown and the aftermath of it. While Kano remains under lockdown, it's more stringent in the urban areas, less effective in the rural areas, and this also has implications for TB case finding. Number of cases are still increasing. Overnight, Lagos reported almost 200 cases. Kano is still reporting a lot of cases as well, while Abuja seems to be slowing down in terms of the epidemic curve. Next slide. I'm going to talk about the impact on the TB program in 3 perspectives. The first is the impact on private sector operations as a whole. The second is on the impact on Shops Plus TB program activities. And the third will be the direct effect on the patients. That's the disruptions in TB services cascade and case notification. Talking about the impact on COVID-19 response in the private sector. So the first case in Nigeria was imported, came from someone who came from outside the country. And for the next few weeks, that was the pattern. A lot of the cases were people that returned to the country. So there were people that could afford private facility patronage. And so it was not a surprise that the first few cases reported to private health facilities. And as a result, the private sector as a whole came under a lot of criticism from the government and also closure in many instances for attending to patients who turned out to have COVID-19. In Kano specifically, the government asked private hospitals who do not have enough resources for infection prevention and control to close their facilities. And of course, as a result of this, private providers became very apprehensive. They didn't want to screen or attend to patients who have cough or fever, either because they are afraid of COVID-19 or because they are afraid of what the government will do if they discover a case. So we have also a reduction in health workforce going to the facilities as a result of the lockdown. So health workers could not get to work, even though they were counted among the essential service providers who could go out in spite of the lockdown. But because of transportation issues, there was a disruption in public transportation, they could not get to work. All these had effects on private sector functioning as a whole. Next slide. And as a program, the Shops Plus program started working from home, started telecommuting. We didn't have access to the offices and we didn't have access to the facilities in many instances. We had to stop physical mentoring and supervisory visits. Our hospitals, some of them were closed down. In Lagos, about 3 for-profit hospitals got exposed to COVID-19, among the Shops network, and they were closed down. The index case in Kano also went to a Shops Plus private facility and was promptly closed down by the government. We have 11 other hospitals in Kano closing down out of fear of exposure or fear of being sanctioned by the government. We also had to put our community outreach events on hold because of the limitation on the number of people that could gather because of social distancing. And of course, we have the risk of treatment interruption among the patients who are already on treatment because of not being able to access treatment in their facilities. Next slide. Now, going to how it affects the patients. The first thing that happened after the lockdown, and even before the lockdown, was a reduced hospital attendance, leading to a reduction in OPD footfalls. I'm showing here the trend of OPD attendance, where you will see that the OPD attendance reduced from March to, between March and April by almost 33%, from 165,000 to just 106,000 in Lagos and Kano. And the screening also went down, that reduced by almost 24%. Providers were very anxious to screen, apart from the patients not coming to the facilities. Providers did not want to have contact with patients that have cough or fever because they were reluctant to be in contact with them, and they didn't even want to attend to them in case they have COVID. And of course, patients also were reluctant to admit their symptoms of cough and fever. And on the next slide, you will see how this affected our presumptive identification and of course, case notification. In addition to that, we also have reduction in testing rates because providers were not willing to collect sputum samples. So even when they attend to the patient, they don't want to collect the sputum samples as they used to do. So they would rather send the patient to a COVID center to be checked for COVID before attending to them. Patients were also unwilling to produce sputum samples in some instances. And then we had disruption in sputum transportation system because the riders could walk, but the adult transporters who depend on public transportation could not move the samples as they used to. So we had to streamline the riders' activities. We also have long turnaround time for results from the labs and reduced treatment enrollment rates. Next slide, please. So we had to adapt, and the first thing we did was to telework, and then we provided PPEs to frontline workers. We knew part of the anxiety the frontline workers were having was because of the risk of exposure. So as much as our budget could allow, we provided PPEs, first to our program staff, the field officers who had to continue mentoring because they had access to move. And then we had letter of support from the NCBLCP, that's the Nigerian TB program, to ease movement, so that, to identify them as TB workers. And of course, we went virtual for all our meetings. One very remarkable thing we did was to hold orientation sessions for the providers. We knew the reluctance and the fear stemmed mostly from not knowing enough about COVID-19 and how to differentiate suspected COVID-19 cases from presumptive TB cases. So we had a lot of training sessions on infection prevention and control, and then on how to diagnose TB and COVID. We also went to the clinical aspects of it and did sessions on radiological diagnosis of TB and COVID-19. Next slide. We went virtual in our mentoring and supervision. We used Zoom a lot for our external meetings and use WebEx for the internal meetings, use Google Hangouts for meetings with the clients, with USAID teams. We monitored our teams on the field by, virtually, phone calls, WhatsApp messages, We had long sessions, reviewing the data at least once a week, and also with smaller teams many times a week. And you know, we're able to monitor the cascade through the entire period of the lockdown. We also got data on who was open and who was closed. We developed a call guide so that our network officers who had to call the facilities were calling in a standardized version, you know, and so we had all that coming in. Next slide. Our hospitals also adapted a great deal. Many of them took screening to outside the facilities. Because of the nature of the private facilities, many of them are small, not having enough space, especially in Lagos. So they did the right thing and moved screening to outside the facilities. They have canopies outside, and they have focal persons that, or triage nurses that are able to separate the patients and identify those who are likely to be presumptive TB cases and suspected COVID-19 cases and refer them appropriately. We have the National TB program also stepping in just before the lockdown to supply at least 3 months stock of drugs to the facilities to ensure that the patients get their drugs. A lot of facilities started establishing hand washing points outside their facilities, which they didn't have before, so that when patients come in, they can actually wash their hands before coming to the facilities. And of course, apart from the few that were able to supply to them, a lot of the hospitals bought PPEs for their own staff. Next slide. One remarkable thing we're also able to do was to monitor patient adherence. At the beginning of the lockdown, and also a little insight into the lockdown, we gave 1 month doses of anti-TB drugs to the patients. Because the patients, some of the patients had gone for their appointment earlier, we had to make phone calls to all the patients. And this pie chart shows kind of response we got in the 2nd week of the lockdown. And for those who couldn't come, we made alternative plans on how to get the drugs to them. Riders took drugs to some of them, the network officers, the field officers went to give some of them, and remarkably, private providers also went to provide drugs to the patients at home. And we also placed phone calls to monitor the adherence of the patient to treatment so that we won't have treatment interruption. Some hospitals took the initiative, asked us about it, got the patient's consent, and established patient support groups on WhatsApp. So there will be that interaction. Shibu mentioned building relationships, and this is very important in private practice. So the hospitals wanted to reach out to the patient, especially those that got closed down at the beginning, you know, because of exposure. They went ahead to create WhatsApp group for the patients so they could maintain interaction. Next slide. We also went virtual for data collection. Fortunately, because of the delay in having the first case in Kano, we already preempted that there was going to be a lockdown because of the population and the population density as well. So we are taking out of preemptive you know, measures in Kano when Lagos was on lockdown. So we had rolled out a digital app, TB Star, is an app for TB screening and tracking for accelerated referral and reporting, which enabled providers to report virtually. We had plans to roll it out like a month later, but we had to fast track that to enable providers to report on time. And also we created ODK, you know, data collection modules for the network officers to be able to record their supervisory outcomes when they go out. And for the monthly reports, we put in a Dropbox that people do not have to have physical contact with each other when they are submitting their reports for the paper, for the backup as MOVs for data entered in the digitally. In Lagos, we had the challenge of getting providers to scan e-copies of registers and MSF, you know, to us. That worked a bit for Lagos, but for Kano, we had rolled out TB Star, and that was helpful as well. Next slide. Looking ahead to the plans that we have, you know, how the private sector can emerge stronger post-COVID-19. There are plans on, you know, going on to integrate COVID-19 screening into the TB Star TB screening, such that in one go, providers can actually screen for both TB and COVID-19 and have, you know, the ability to separate, you know, those who have TB, suspected to have COVID-19 from presumptive TB cases. That's already in the works. And of course, the plan to roll out a mass in Lagos as well, like we've done in Kano, and also scale up even further in Kano to more providers. We want to intensify infection prevention and control, set up IPC teams and focal persons in our private facilities. That used to be a public sector thing, but we have seen the need, and that is the way to go. Instead of shutting down hospitals or making private providers refer all their patients, the basic thing is to ensure universal precaution, and we intend to do that By setting up infection prevention and control teams in all private hospitals that we support and developing plans with them, and identifying a focal person that will ensure that these plans get implemented. For case finding, because of the drop in the OPD attendance, we know we have to go to the community. And fortunately, we developed a guideline in country. The NTB-LCP and WHO worked on this guideline that will allow house-to-house search in high burden areas and also contact tracing for TB patients who have recently been diagnosed or even are already on treatment. We plan to do that to increase the OPD footfalls and the facility utilization in the private sector. We're also targeting drug shops and pharmacies for IPC orientation. One is going to happen in Kano this week. In the country, we have more PPNVs in northern parts of the country. We have more drug shops, and they are interfacing with the patients day in, day out. And so they need to be trained on infection prevention and control, and also supported for referral and treatment support for the patients. Thank you very much.
Thank you so much, Bola. That was an excellent presentation. Really appreciate hearing you talk. And I also want to say that I appreciate both you and Shibu being so well prepared in sending the presentations beforehand so that we could actually allow to share both of them. I would like to hand over to William and see if he would like to moderate some of the questions that have come up. And thank you everyone for putting questions forward. William, please go ahead.
Great. So thank you very much for two excellent presentations. Very, very informative. So I would actually like to reflect on the earlier webinar that was presented within this group and recommend it to anyone who hasn't seen it yet. So there are a couple of themes from that earlier TB COVID webinar, which I think were really reflected here as well. So one was that in the middle of a crisis, you can build on existing opportunities, but it's possibly not the time to start from scratch. So I think there were some really nice examples here. Shibu talked about existing voucher schemes. So if you've got experience in vouchers, you can go ahead and adapt that to the new situation. But learning from scratch how to implement vouchers may be challenging. So I think that was interesting to see that message from the earlier webinar kind of amplified. And the second one is around trust, which maybe we can explore more with the presenters. So I think if there's trust between public and private, then again, you can build on that. If there's suspicion from the past, and that's the way that you're operating, then it makes everything more challenging. So starting with that as a question, I'm wondering if the two presenters can respond to the idea of whether the COVID situation has made it more or less promising for future public-private cooperation. We've seen opportunities in India. We've also seen some challenges with the private sector in Nigeria getting some blame. So do you see this opening minds and opening future opportunities, or do you see it actually creating more suspicion and more challenges for the future of public-private cooperation? Shibu, maybe you can start on that one.
Yeah, so, well, I mean, I think this is an opportunity to actually think about how in pandemic response, we could actually leverage the larger private sector, because we are talking about 50% of the health system, at least minimum 50% of the health system. So that, I think this opportunity, I mean, this need to be seen as an opportunity to discuss about it. How do we, and I mean, and Government of India has actually instruments also. One is policy, and then instruments like Ayushman Bharat and PMJY. So this probably need to create more space for private sector, I would say, because given the spread of it and the reach of it and access of it. But immediately it's largely government centered, because the government would want to actually kind of control the situation, because that's where besides some leveraging of beds and then ICUs and ventilators, but there is no kind of comprehensive engagement. Even the private sector labs are not completely opened up for the COVID testing. So there have been requests. There are multiple challenges for that, but I think this should be a platform to discuss that. I mean, I'm very optimistic on that, because given that the directions probably it will shape up into that more a PPP pandemic preparedness. at least in India.
Great, thank you. And Bola, would you like to respond for the Nigeria perspective?
Yes, I also see opportunities. What I didn't mention was that in Lagos State, the government came around to realize how important the private sector was, and they started a process of accreditation. They want to visit hospitals and accredit them if they had the right infection prevention and control strategies in place. And in Kano, the government came around also to supply PPEs to private providers. In fact, about 80 out of 100 private hospitals that were given PPEs by the government of Kano State were in Shops Plus network. So these are opportunities. I mean, there have been discussions after the initial reactions of closing down facilities, but the government realized that patients will always continue to go to the private sector. And another positive note is that private hospitals are now more responsive to infection prevention and control. I mean, what we couldn't get done for TB for years are now happening in hospitals. They are taking infection prevention and control more seriously. And we have hospitals shutting down their central AC system for natural ventilation and for environmental control of infection. So I see opportunities, and I think we can leverage a lot on that for further private sector engagement for TB.
Great, thank you. Yeah, I think there's nothing like a crisis to make people realize that they need the entire health system. So there were a number of questions from participants who were looking at sort of further into the future. So I think your presentations were really fantastic on the immediate mitigation steps. So I'm not going to go into that in more detail, but a number of people were wondering, you know, what does it look like as we get towards recovery in terms of COVID, then recovering the TB response? Are there discussions within JEET? Are there discussions within Shops Plus or NTP Nigeria? How do we kind of deal with the backlog of diagnosis in particular? So again, I'll go to Shibu first.
Yeah, so again, I mean, so we would want actually the wall to be there to paint. So I mean, at present, there is actually, the wall is still actually not there. We are painting on a virtual wall, I would say. So when the shops are open and when the private sector is open, so we also actually discussed about aggressive, case finding, using the existing providers, maybe like looking to the delving into the contact tracing more aggressively, because that was some area which we were not actually kind of very focused on. Maybe actually pitching with the LTBI something, because all these all depend upon actually Government of India's policies and guidance towards that. These are very early discussions to catch up notification. We are just, we are just actually kind of digesting the crisis now, and then understanding how to actually kind of, when these people actually open up, how do they, and most of the facilities are not going to be open up in the full scale. So, but so that's another challenge. The waiting. So the shape also of the private sector also changed, because in India, the private sector also offer a lot of hotel facilities like waiting area. You can see, even there is an element of entertainment there when you are actually going to see the doctors. The doctors also might switch to, started actually switching to online platform, pre-booking, contactless, actually going contactless, at least a few of them. So I think it's too early to actually define and say, okay, this is going to be like this, and then we can actually hop on everything. So I still actually wonder how we can actually kind of mitigate this thing over the next coming 3-4 months. And there is no, bump up to this level, because we have been doing quite well. So how do we get to that level is still a question to actually kind of still need to be deliberated how to get it.
Okay.
Thanks, Adebola.
Yeah, for Nigeria, the NTP monitored as monitoring data very closely, and we've seen the decline, you know, in TB notifications. So we've taken some very preemptive steps. The first thing National Program did was develop an SOP for integrating TB and COVID-19 triaging. I mean, it's obvious, let's not deceive ourselves, that COVID-19 may be here for quite some time, and providers' apprehension will still be there. So one of the smartest moves we've made is to integrate TB screening into COVID-19 screening, so providers can do both at the same time and feel empowered to do it. And on our part, we are supporting the NTP by rolling out TB Star, like I said, and integrating COVID-19 screening into TB Star. Secondly, we need to go into the communities. So the national program developed a tool, an SOP as well, for house-to-house case search with some laid down guidelines and principles to ensure that the volunteers and the health workers are protected in the community. And that should, to some extent, take care of the backlog of the TB cases. But if they didn't come to the facilities, that means they are home. And we need to get them, from the communities. So that is already going on. And we're also riding on the active case search team for COVID-19 in some areas to get to the TB patients, that may test negative for COVID-19. And of course, we're also looking at instituting infection prevention and control teams in all facilities. So all these three things are happening. And telemedicine is an area that the NCP has also mentioned that we need to get, some private providers have started doing telemedicine in the private sector. It's a strong area for us to work, with, because it's the future, most likely, for a lot of consultations going on.
Great, thank you. Bola, there's a very practical question for you. Is TB Star in the App Store so it can be used in other countries?
It's in Google Play Store, but it may not function in other countries because of the networking that has to happen among providers. So we have uploaded only Nigerian facilities on TB Star. So it's on Google Play Store, but it may not function in other countries.
Okay, great. There's some practical questions for Shibu. It's less about COVID, but maybe just some very quick responses on how the model works. One question was about CBNATs being done. Are they done in public? If so, how does the public sector manage such a huge load? Are notifications done by the provider or the hub agent? What's the authentication? And how is ICT used for adherence? So CBNATs, notifications, and ICT for adherence. If you just a very quick response on each would be great. Thanks.
Yeah, the CBNAT actually in the model, CBNAT is predominantly done in the public sector, and there are patchy examples of getting it done because we recently got resources from the Global Fund to actually pay for the private services as well. But it's, again, that's in a restricted geography. The notifications in the heavy load facilities are done by the project staff, which is hub agent. They are actually entering directly into the NIC share. And subsequently, the verification is done by, because there is a direct benefit transfer from the government of India. So there is a validation process done by NTP staff and the respective NTP manager. So that's how, whether this patient is real or not, whether what kind of diagnosis has been done and all these things. That gives an opportunity for the public system also to interact with the private doctor. The third one was on what?
ICT for adherence. What does that look like?
So ICT adherence, though it was actually piloted, and then there are certain states that have taken it, and Government of India has given actually resources. There were some challenges in actually scaling it up because of the two kind of products came into the NTP system. So because the sleeves were not available, this is an opportunity to actually, even Government of India directly also says that, okay, this is an opportunity to switch into that. There is no dearth in resources. This is clearly an indication that, and not only for adherence, but as Madhu always says, that this is an opportunity to reimagine the TB care situation, because this is somewhere where we need to actually move into that framework altogether.
Great. And maybe I can just, before asking Madhu if he wants to make a comment, Bola, if you can just have any final reflections on once we get over coping with the emergency, do private sector TB services look different, do you think, in Nigeria?
Yes, I think private sector TB services will be different. First and foremost, they are taking infection prevention and control very seriously. And because COVID-19 is also a respiratory illness, there's more awareness, about respiratory illnesses as a whole. And we've had the opportunity to discuss both on using the same platform. They are listening to us more, they are more attentive, and they are ready to learn. So yes, I think private providers will be more interested in TB services and respiratory illnesses as a whole.
Great, thanks. Madhu, do you want to make any
just
comments
one
or
comment?
questions?
I think just one comment, William. So this probably, so we also run a aggressive quality of care drive the recent months, and we've seen that there is a bump up in HIV testing as well as in microbiological testing. And this is an opportunity to reiterate that, and then probably work with the private very closely to drive for the quality of care. So there is an amount of actually overdiagnosis. We all probably state that multiple times. So this could kind of regulate that.
Yeah.
It's more a comment. See, if let's just take India for example. So Shibu, in a normal pre-COVID situation, what would be India's expected monthly notifications? About 200,000 a month, 2 lakhs.
Yeah. So I mean,
You take
I
3
would say,
million per year.
so it's actually
overall.
kind of yeah. So that was the kind of situation. So,
So just let's say
I would say that it's actually roughly around 12,000, 15,000 is actually kind of daily notifications, 12 to 15,000.
so for a month it would be what?
I mean, somewhere around.
Let's say 100,000 a month, okay? Just conservatively. I mean, in 2 months of lockdown, we have pretty much not picked up something like 200,000 patients, right? So now, if there is another month of lockdown, that number is going to climb. So I think the point I'm making is we almost now need to kind of anticipate how much of a backlog cases, undiagnosed patients we will need to see in the coming months, in addition to the regular monthly load we would expect to see, right? You have your backlog added to your existing monthly load. And if you do that math, and I think each country needs to do it now. So what would you or should you ideally expect to detect as backlog and new cases, say for the month of June in Nigeria, for the month of June in India, for the month of June in Indonesia, then track what you're actually seeing in June to see how big a residual gap that you have, and then what pickup activities you need to do to even bridge that gap. Because every passing month, your backlog gets added to the next month, right? And we also know with all this lockdown, people will present with more severe disease because the even already existing diagnostic delay has now been amplified to maybe twofold. So maybe one quick way to get that backlog reduced is, while GeneXpert and smears are heavily dependent on good quality labs, can you at least get chest x-rays pushed out very quickly to bring that backlog to something more manageable? A chest x-ray with the CAD, for example, will at least help us go closer. The only vexing problem there is confusion between COVID and TB on a chest x-ray, which is also not easy to discern. So I'm just wondering, what is the fastest way to bring that backlog down, say starting next month?
Yeah, so that could be one possibility. I think that massive X-ray screening, or actually push for X-ray vouchers. Actually, you saturate the market with X-ray vouchers and ask everyone to actually go for an X-ray voucher very liberally. So, and that is a sensitive test as well. Now that we have the solutions of, Indian solutions, QRI, which also enables that. And we have decent penetration also, because in private sector, if you look at of X-ray facilities and dependency on X-ray, because it's very well aligned with their existing behavior. And that could be one area probably, and exponentially we will kind of do the catch up.
I think tracking the backlog gap starting, say, next month, and tracking the number of reduced private facilities, because private facilities are not going to come back online at full force, right? It'll take them a few months to ramp up. So I fear that between the greater need and the reduced capacity, we're going to have the whiplash effect of this backlog spread across months, because even the government is still dealing with COVID, right? COVID is not gone anywhere. Private sector is at a lower capacity, and each month's backlog is getting added to the next month. So trying to match this bit, and I think we need to talk to people like NIM and others to see how many months of mop-up work, extra work will we need to even bring the caseload back to the regular monthly load that we were seeing pre-COVID. I think some serious thinking is needed here. Making assumptions on, say, 50% capacity is back in private. Government is still 70% COVID, maybe 30% is still focused on TB. Doing that level of analysis would be critical. Otherwise, I fear that this backlog effect will be incredible, not to speak of the transmission issues.
Yes, thank you, Dr. Pai. It's we'll do the calculations like you said. We have identified 3 ways of mopping up. The first is what I've said, community outreach through house-to-house active case finding around the private facilities. We also thought about drug shops in northern Nigeria. The patients are still going to the drug shops. we have facts, and this week we're actually rolling out COVID training, for the COVID-19 and TB training for the drug shops on how to screen safely and protect themselves. In fact, we had to adapt in Northern Nigeria and give, some of the PPEs to the PPMVs, to the drug shop, but they are the ones seeing the patients right now. And of course, the third strategy is what you said, X-rays. Like I said, one of the slides I showed was our webinar on COVID-19 X-rays and TB X-rays. Kano showed us that we couldn't stop private providers from seeing their patients, and they're going to do X-rays. So we needed to train them on how to differentiate the two. And we had like a 2-hour webinar on X-rays for reading X-rays from TB and COVID-19. And we're doing the same in Lagos next week.
I know we are out of time, so Petra is going to ask us to close, but I'll just make one quick thought. It's not data-based or evidence-based. I predict the amount of backlog patients who've been patiently waiting for lockdowns to lift will be immense. In other words, you don't need to go looking for them in active case finding. They will be hammering down every door they can because they would have been sitting on symptoms and suffering and having advanced symptoms for weeks and weeks. So I think the system is going to be flooded with people seeking care whenever restrictions disappear. So I would rather get them when they are accessing health facilities rather than go chasing them in the community, because the effort and the yield needs to be seriously thought through. I wouldn't just say, let's go do active case finding, because people are desperate for care and they will seek care. And I worry that there aren't enough facilities to receive them at this point.
All right, thank you.
All right, Petra, over to you.
Yes.
Thanks, William, Shibu.
Thank you. Thank you for throwing out some new ideas for future webinars. I feel the questions coming in. I would like to thank everyone. Thank you, speakers. Thank you, William and Madhu, William, for moderating and picking up the questions, especially during these technological mistakes. Sorry from my side. Thanks everyone for being patient with having the presentations up in not the most visible way immediately. I would like to thank all the participants for your engaging questions. Everything that has been, if you still have questions reflecting after these presentations, please feel free to send them to us. We will get back to the panelists and try and get you answers if you have specific questions on their programs. These have been such valuable on-the-ground experiences with really practical ideas. So I can imagine that some other countries would like to learn more details, and we would be happy to help you, give you some further insight on specific questions that you might have. So please reach out to us on the network, on Twitter, or through email. We will be available. We will be uploading this whole webinar, the recording, all the presentations, so you can go through it at your own time again as well. And please look out for future webinars. We are planning more webinars in the next 2 weeks. There will be a next webinar coming up, so look out for the announcements. Thanks everyone. I think that's all for today. I'm going to launch a quick poll, so anyone can give us some quick feedback, that would be most appreciated. And I would like to, with this, close today's webinar. Thank you for the excellent presentations and discussion.